Okay, so thank you everybody once again for joining. Um, I was going to I was going to record just like that and upload the video, but it felt really awkward just talking to myself. That was why I said, if anybody is available, we should join in so that at least it will feel a bit interactive. So over the course of the next few days, whenever I'm free, I'm just going to let us know. Anybody that is available can join the meeting, and it's going to be recorded, so it's not like you're going to miss anything. It's just that I would need somebody, like I would need people to be present so that I even feel like like I'm running mad. All right, guys. Yes, so I want to just explain. Lillian, your video is on. We're recording. Okay, so the reason that I'm going to be having these impromptu sessions is just, to explain the courses for which the exams are proctored. There are two courses that we have that the exams are proctored. The first one is, oh my God. The first one is the MPH 8101, and then the other one is MPH 8107. MPH 8101 is Foundations of Public Health, and then MPH 8107 is Survey and Research Methods. So for what we're doing today, what we're going to start with today is MPH 8101, which is survey and which is Foundations of Public Health. That's what we're going to do. Just to explain a little bit, because a couple of persons have asked, what does it mean for the exam to be proctored and all of that stuff. So, in a typical exam setting, you're going to have invigilators. And invigilators are there to monitor and make sure that there are no malpractices, right? But MIVA cannot send invigilators to everybody's houses to say, go and monitor this person while writing the exam to know if the person is going to do any sort of malpractice or not. So what's going to happen is that we do something like an online monitoring. Okay, that's where the concept of the exam being proctored comes into place. So we're going to be told the software that we're going to use. You basically download the software or like install it in to your device. When you install that software on your device, what is going to be is like, if you can imagine something like let's say like CCTV, basically. So it's going to be monitoring your activities. But this one is not just CCTV. I'm just using CCTV as an example. What this one is going to be doing is that, it's going to be sensitive to the sound around you. It's going to be sensitive to movement. It's going to see if you're trying to switch your screen. Maybe you want to use something else. It's going to be monitoring the exam. So it's basically like you have somebody invigilating you, but this time it is technology. It's not a human being doing the invigilation. Okay, so you want to be really careful. Now that's why I want to explain these topics, because it's going to be like the normal exam. And if you don't know it, you basically don't know it. You're not going to know what to write. And this is not like MCQ where you are going to have the privilege of like selecting, doing what do they call it? Like tumbum and just see which one falls in and you choose that one. No, this is essay. So it means that you need to have digested this topic. The topics, you need to know them, and then you'd be able to reproduce these topics. Okay. So that's why we're going to be having these impromptu sessions. And it's impromptu because really at evenings my day gets very busy towards evening. So this around this time, whenever I'm free, I'm just going to put up a link and anybody online can just join in, and let's rattle. All right, so we're going to begin with MPH 8101, which is core functions of public health. which is, sorry, Foundations of Public Health. That's MPH 8101. We already have talked about MPH. We've already done the study session 1. We know that there are 6 study sessions. So we've done study session 1. If you missed the video, or maybe you weren't in that discussion, you can look for the video on our YouTube. It's there. So you can look at the study session 1. There's nothing much there, so I don't think it's necessary for me to start talking about it all over again. I'm going to start from study session 2. I'll see how we can do study session up to study session 6. Let's just get this one out of the way. Then we do MPH 8107. All right. Good. Now for study session 2, what we are talking about, or what the material is about, is talking about core functions of public health and essential services of public health. We know that in public health, there are basically like so many specializations. You can say after doing this master's that the area that is really interesting to you is health education or health promotion. You can say the one that is interesting to you is policy analysis. You can say it's epidemiology, it's biostatistics. So there are so many specializations under public health, right? Now, all of this specialization put together is what makes public health. All of them put together, that's what makes public health. Now, we now want to talk about the core functions of public health as a whole. The entire thing we're doing in public health. What are the core functions? As we know, function mean like purpose. It means roles. So what's the role of public health in society? Like what are the functions of public health? Now, let me give an example using something common. For instance, I can say functions of McDonald's. The functions of McDonald's, their functions there would be, they can say their function is to prepare food to serve customers. That's their function there. Okay? So in public health, we have core functions, and there are 3. All the lots of specialties that were mentioned in One Health, environmental health, biostatistics, epidemiology, this, that, all of them put together make up public health. And the core functions in public health, we can broadly categorize them as 3. Assessment, number 1. Policy development, number 2. Assurance, number 3. Those are the 3 core functions of public health. Now, I'm giving an overview, right? We're going to talk about it in more detail. We now said that the other part of the topic is also essential services. So this study session that we are looking at, the summary of it is they're talking about core functions of public health, number 1, and essential services, number 2. So the part A of this chapter is on core functions of public health. The part B is on essential services, but both of them are related. Both of them are related. Okay? So how are they related? Let's go back to the example I gave. McDonald's is an eatery or a restaurant. We know it. So if they say our function, meal prep and service delivery, those are our functions in this eatery. Now, there's now, just saying that that's our function, it doesn't put food on the table of the customers. It doesn't like, okay, and so there's now the service part of it. The service part of it is the place where these functions are operationalized. That's the place where these functions are operationalized and these functions, they come alive. We make it real to people. We make it real to ourselves. We make it become tangible. So if their function is, if they say our core functions are meal prep and service delivery, to operationalize it, the meal prep will now include that there are going to be people who are going to write down the recipes they will use. There are people who will go to the market to buy that recipe. It would involve people who would, it would involve actual cooking. It would involve, washing the dishes. All of those things are encapsulated within meal prep. So those services, that's how they operationalize their functions. That's how they make it real. So in public health, we have core functions. But these core functions, like, okay, you know how they say in Nigeria, like, who will help? So who does he help? I know your core functions, and so these essential services, they are now the things that make the core functions to come alive, make it real. So that's what is in the part B of the study session when you go there. If you even have a device, I would advise that like you can open it and let's follow along. You can open that material so that we fly together. All right. So I've explained the relationship between core functions and essential services. And I said that the core functions of public health, there are three. So I need you to say it after me. Number one, assessment. Number one is what? Just say it in your mind, even if you're at work. Okay. Number two, policy development. Number two is what? Number three, assurance. Assessment, policy development, and assurance. Those are the three core functions of public health. Okay, now the essential services of public health, there are 10. There are 10 essential services of public health. Ignore what's on my screen for now. This was when I was still trying to record and explain, but it felt really weird talking to myself. Under assessment, we have the services that are under assessment. Under policy development, we have essential services that are under policy development. Under assurance, we have essential services under it as well. Now, remember I said 3 core functions, 10 essential services. These essential services are the ways that the functions are being operationalized. For assessment, there are 2 services under assessment. So assessment have 2 services, 2 essential services that we use to operationalize assessment. It's not this one on the screen. No, this one on the screen is a different thing. I was trying to explain assessment itself. So this one I'm saying now, just listen to it. If you go to our textbook, you will see the part B, essential public health services. You will see a diagram there. Under that diagram, like the diagram is a circle. So you would see that there's assessment. You will see two sectors or two sectors under assessment. If you look at the parts where there's policy development, you will see 4. If you look at the parts where there's assurance, you will see another 4. So for assessment, we have 2 core services. One is to assess and monitor population health. You don't need to cram them all. When you go back to read, you will study it and just learn it. You don't have to cram now. And then investigate, diagnose, address health hazard and root causes. So those are the 2 services that are under assessment. Policy development, there are 4. Assurance, there are 4. So 2, 4, 4. These services are the ways that these core functions are being operationalized. So the part A of study session 2 in this course, it focuses on talking about the core functions of public health. And that's the main thing I'm going to talk about. Then the part B now focuses on the essential services. Now, because you already have this overview, by the time you go to study part B, it's going to be really quick. Although its length is bulky, but because you already have this overview, you know where you're coming from. It's going to be quick for you to understand it. I'm not going to go into it in detail because, it's just so many things but if you read it, you would understand. So I just want to give us this overview to make it clearer to us. If you are following, please, can you just indicate, let me know that we are still here and so far, we are together. Okay, thank you. All right, guys. All right, guys. All right, guys. All right, guys. So, let's now focus on the core functions, okay? Let's now focus on the core functions of public health. There are three: assessment, policy development, and assurance. Now, the thing is that the three of them, they are almost like one happens and then leads to the other and then leads to the other. You can follow it. Assessment is where we are trying to find out what is the status, what is the health status, what's happening in our population, in our communities, what's happening. By the time you now know what is happening, it will result in us doing what? Implementing policies, coming up with policies. So that's now the policy development. Now we've made the policies. What's now the next thing? The next thing is now to carry out the policies, to implement it in the society, to operationalize it in the society. That's now the assurance part of it. So from assessment to policy development to assurance. Okay? All right. Now, let's look at assessment in detail. Let's look at it. Assessment, the way it is commonly defined is that, or the way it is commonly explained is that it is like the eyes and ears of public health. Assessment is the eyes and the ears of public health. It is in assessments that, when we say something is the eyes and the ears, they are sense organs. You use them to take in information about what's happening in your environment. It's your eyes you will use to see, to know maybe something is happening. Okay, we need to run. Your ears to use them to hear, taking information. So that's what assessment is. For us as public health practitioners, the assessment aspect of public health is the part where we are taking in information. And mostly this information comes in the form of data. So we're gathering data, we're taking in information. And it is this information that we use to know if something is happening wrong in our communities. We use it to assess the health status of our communities. So that's the assessment part of it. Okay? Otherwise, if there's no assessment, you can imagine how it will be. It will be as if we are blind people. It will be as if we are blind. It means if you do, you can fall into a ditch because you can't see. It means we are going to make policies that don't help anybody. We're basically going to be wasting our time. So that's the assessment part of it. Now, assessment has three components. Okay? You see how everything in this place used to give birth. First of all, we have three core functions. Okay? Now, the three core functions, we said assessment, policy development, and assurance. And now I'm saying that assessment itself, which is what we're talking about now, the eyes and the ears of public health, the sense organs, the things that we use to take in information, and mostly the information, it comes in form of data. And I'm saying that it has three components. So if you see my screen, you see that I already drew on my screen. Okay? So there's health monitoring in blue. The ones in blue, those are the three components of assessment: health monitoring, surveillance, and needs assessment. Okay? Health monitoring, surveillance, and needs assessment. So those are the components, those are the things that are under assessment itself. So now let's talk about health monitoring. Let's talk about health monitoring. When we say health monitoring is basically what it involves, or what it is that we're collecting data in health monitoring. We're collecting data. General data is a broad thing. It's general. We're taking general data. It's not specific for any particular health issue, because that's what differentiates health monitoring from surveillance. If you hear surveillance, It's specific. Surveillance is particular for their specific diseases, that when you hear surveillance, you know that the person is referring to. You ask the person that, okay, what is the health event? What is the disease that you're talking about for this surveillance? Is it cholera? Is it yellow fever? Is it Lassa fever? But for health monitoring, it's mostly general. We're just taking data, general data. That's what's happening in health monitoring. It's mostly general. So we collect data, we analyze this data and interpret it. If you don't analyze the data, we can't get any information from it. And even after we've gotten the information, we need to interpret it to all the necessary stakeholders. So that's what's happening in health monitoring. It's here that we will be able to observe trends. Are there diseases that are occurring more than we expect? Our indices going lower? It's health monitoring that we are using for all of this. Now, remember I said that all of these things, the health monitoring, the surveillance, and everything we are doing under assessment is mostly data, where we need lots of data in this aspect of public health. So what are the sources of data for this health monitoring? Vital statistics. So when we say vital statistics, I've said it at in our previous classes. When I say vital statistics, we're talking about like things like births. What's the births? You know, how many births are we recording? You know, when you give birth and they say you have to go and register, you get your birth certificate. You go to the National Population Commission. All those things, they are vital statistics. There's a reason why we are collecting them. Because by the time we see that, okay, we're having more births, it points to something. Also, death. If you've lost somebody before, you'd see that one of the things you have to get is a death certificate. That death certificate, as you're collecting it, the healthcare, the health body, we also need it because it helps us to, it's also a way that we are getting our own data. There you're going to see, okay, what killed the person? How old was the person? That's how we will even get to know what, you know, the average lifespan is. By the time we see that more people are dying at this particular, who is operating my screen? Jesus, please. Please now, who is now presenting? Hello, Victoria. I don't even have access to my screen anymore. Oh, Chim. Oh God. I think I made a mistake by making this thing to be collaborative. Victoria, if you can hear me, please. All right, guys, please, let's not touch our screens. Okay, I don't want to start trying to, you know, change the settings or anything. It's just going to break my flow of thought. Please, let's try not to touch our screens if it's possible. Biko no o. Please, so that it doesn't interrupt us. Okay? Thank you very much. All right. So, what was I even saying now? Okay. Yeah. So the death certificates, you know, they are going to write what was the cause of death? What made this person die? How old was the person? Is it male or female? That's the way that we get our data. So vital statistics, when you hear vital statistics, think of death, think of birth. Some people would include like marriage. Some people will, there are different things they can include under it. Okay? Now another data source we're interested in under health monitoring is health service utilization. Under health service utilization, we're trying to see how many people are even using the health facilities that we have? How many people are our facilities able to cover? What's the coverage? That's the health service utilization. What is the behavior of people? What's people's attitude towards health services? Then another source of data is population survey. An example of population survey is the DHS, Demographic and Health Survey. DHS is, it's something, it's organized by, or it's funded by, I think, the USAID. And they work in hand with different countries, different ministries of health across like low and middle income countries. So what's happening there is like they will fund them, and then they go into the country and try to get data across all the regions, across, if it's Nigeria, for instance, every state will be captured. Every local government, they will try to capture every state. So that's DHS. That's a very popular population survey. Okay? So these are the ways that we get data for health monitoring. Now, there's a diagram there in our textbook on page 55 that I was trying to recreate here. Please, once again, let's be mindful with the screen. Please do what you can to not touch the screen, please. I beg us, so that, because we are collaborators, and if we touch the screen, let me see. Okay, I can actually just change it here. Okay, I think I can even change the settings here. All right. Okay, so it be like I don't change them now. Nobody go fit play with my screen anymore. I know people are not playing with it. I think maybe you're trying to increase the dimensions, and that's what's affecting it. All right, guys. So I was trying to recreate this diagram. That's what is here. Let me zoom it out a bit. So the diagram, you would see it in our textbook. You see it in our textbook on page 55. By textbook, I'm referring to that very comprehensive one, but I guess this is obvious enough. All right. So if you've seen this diagram before in the textbook, just give me a reaction. If you've seen something like this, if you've seen it before in the text. Okay, a couple of us have seen it. A couple of us have seen it. Or it's two persons that gave you reactions. Okay. So this diagram, what they called it in the textbook, is the components of comprehensive health monitoring system. So when you want to set up a health monitoring system, the components. So I'm just going to explain this this diagram a bit. Don't mind how rough it is. I'm still trying to learn how to use this Zoom whiteboard, okay? But look at this. This is the way they set it up, or this is one of the ways it can be set up. So you have here input at the top. Then you have output, outcome, and impact. And then on this side, we have indicators, we have data collection. Okay? So let's talk about it a little bit, and then we'll zoom out and continue the rest of the conversation. So for input is saying, what are the resources? Remember, we're collecting data to monitor our health systems. So on the input aspect of this framework, what we are looking at is the resources that we need, the resources we are going to put in. So inputs and processes. What this column is talking about is what we are going to put in, the resources we will put in. So is it governance? It can include governance. It can include things like manpower. I'm going to use a particular health condition to give an example. It can include things like our health by manpower, like healthcare workforce. That's for input. Output means, okay, oh, we put in these resources. What are we expecting to see? What's the output? What's the services that was delivered? Outcome is like, will I call it something like, you know how they say we have short-term goals, mid-term goals, long-term goals. Outcome is like the mid-term impacts of whatever it is we have done. Then we have impact. Impact is like overall, like after a long period of time, after a period of time, overall, like what were we able to achieve? So let's look at it again. This is indicators, and then this is data collection. So I'm going to use a disease condition to give an example so that it is a bit clearer to us. Okay? So let us say we are using let's say measles. We want to monitor, we're interested in monitoring measles, for instance. So let me use that as the example. Under input for indicators, indicators mean what are the things we are going to be monitoring? What are the indices we're interested in? While data collection, this part is saying, where are we going to get the data from? Indicator is saying, what are we going to be monitoring? What are we monitoring? Data collection is saying, where are we going to get the data from? So let's use measles as an example. Under the input, if we want to monitor it, for indicators, under input, we're going to be looking at healthcare workforce. How many healthcare professionals that give immunization, how many of them are we going to need for this thing? How many of them are we going to include in this process? That's under input. Still under input, we're going to include funds. So it's one of the indicators that we're going to be monitoring, funds. How much are we spending for this thing? How much are we spending for it? Then we go to the next thing. Okay, before we go to that, we are going to now talk about the data collection. Where are we going to get this data from? Where are we going to get the data from? The data that is going to tell us about the funds that we are spending, that is going to tell us about the vaccine supply, that is going to tell us about the healthcare workforce that we have on ground for it. Where are we going to get this data from? So that is what will be inside this data collection column under input. So there you would have something like what now? Where are we going to get this data from? It's basically from administrative sources. So it's administrative sources. That's where we are going to get the data from. Okay. Now we move to output. So we have imputed all of these resources. We've brought healthcare personnel. We've brought in money. We've put in all of that. All those things we're monitoring under indicators. Now we will now move on to the next thing, output. So under output, what are we now going to be looking at? Under output, we'll now be looking at the service delivery. We'll be looking at service delivery. How many people were we able to immunize? That's what we are looking at. The indicator under output. That's the example. How many people were we able to immunize? How many children were we able to immunize? I be vaccinate. If I say immunize. Okay? That's what we're going to be looking at there as an example. Now, how are we going to get this data? That will be this. So let me write, it's just a little bit awkward using this thing because I'm not used to it. So under output, we're going to have Number of children immunized. Number of kids vaccinated. Not immunized, vaccinated. Okay? So that's what's going to be here. Sorry, I'm still learning how to use this Zoom thing. It's just a bit awkward for me. All right. So that's what we're going to have under output, because remember I said that for output, we're looking at what? We're monitoring service delivery. That's the indicator. Service delivery. That's the indicator under, that's what we're looking out for output. So the service delivery here is going to be what? Number of kids vaccinated. Number of kids vaccinated. And how are we going to get this data? Where are we going to get this data from? Basically from all of the immunization centers, right? That's where we're going to get them from. So immunization centers. Okay? So that's what we're going to have here. Remember, indicators tells you what are we monitoring. Data collection says, where are we going to get the data from? What's the data source? Where is the data coming from? Inputs, the column for inputs is saying, what are the things that we are going to be, what are the things we would need? What are the resources that we are going to use for this particular thing? Output is saying service delivery. What did we do with the resource? How many kids did we vaccinate? Then let's move to outcome. Let's move to outcome. So still using the measles as an example, the outcome here could be something like, we now have a decrease in transmission of measles. So we've been able to decrease transmission of measles. So that will be the outcome. Decrease in measles transmission. Okay? So that's going to be the outcome. Now, where are we going to get this data from? How will we know? How are we going to know that there's a decrease in measles transmission? What's going to be in this box below now? How are we going to know that there's a decrease in measles transmission? Which data? Where are we going? What's going to be our data source? It's basically going to be like what we mentioned earlier, those population-based, yes, health survey. Aisha, that's correct. Health survey. So basically like health surveys. That's how we know that, okay, the measles the measles transmission is reducing. Okay. Now, what's going to be the impact in the long run? What's going to be the impact? What are we going to measure to know our impact? To know what's the indicator that we are going to use to measure our impact in this our measles control program that we have done now? What we're going to use to measure impact? We can say decrease in deaths of kids, decrease in mortality. So decrease in measles-related mortality. Okay? So that's the impact. That's the thing we're going to use to measure impact. Now, where are we going to get the data from? Remember the things I said from our vital statistics. All of those vital statistics, civil registrations, vital statistics. All those deaths and births statistics or data, that's how we're going to get it. So from vital statistics. Ignore the mistake in my spelling. Okay? So this thing we have done now, it's like when we are doing a monitoring for when we are doing a measles control program. I hope it helps a bit when you go back to study it. The small explanation I just gave. Okay, so this is health monitoring. We've developed a health monitoring system for a measles control program. So this is just an example. This is just an example, okay? You have the inputs, the outputs, the outcome, and the impact. Inputs is talking about the resources that we go in. Output is talking about the service delivery, the direct effects of our input. Outcome is saying, okay, so what were we able to achieve? Then impact is more like overall, in the long term, what were we able to do? And I said that for input, an example, we used measles control program as an example. And we said that under input, an example will be what? Vaccines. That we need vaccines. So we're going to be monitoring that. Healthcare workers or health workforce, because we need them for this program. So it's part of our input. Now, where are we going to get data to know how many vaccines do we have? How many health care workers do we have on ground? What's our cold chain process like? What's the funding for this thing? Is basically from administrative sources. That's where we're going to get the data. You come to output. Our indicator there would be what? For this measles control program, our indicator would be number of kids vaccinated. That's the indicator. That's the thing we'll be monitoring. Where are we going to get the data for number of kids vaccinated? From immunization centers. That's how we know. Outcome. What's the indicator? What's the indicator we're going to be looking at for our outcome? We can be looking at what? Decrease in measles transmission. Then, where are we getting this data from? Health survey. Impact. In the long run, what were we able to achieve? We're able to achieve decrease in measles-related mortality. And how are we going to know that there's a decrease? Where are we going to get this data from? From vital statistics. So we see that, okay, we're no longer recording deaths from measles. So that's an example. And I just tried to explain that diagram we have in our text. Okay, so we've talked a lot about this health monitoring system. Let's go back, let's zoom out and continue what we're talking about. We're still under assessment. I'm going to be very fast now so that we can finish up. So we've talked about this health monitoring. We said assessment, there are 3 components under it, right? And now we've talked about health monitoring. And we said how we get our data for health monitoring, vital statistics, health service utilization, and population survey. That's it for health monitoring. Now let's move on to the next one under assessment. The next component is what? Surveillance. The next component is surveillance. And health monitoring is said to be general, while surveillance is said to be what? Is said to be specific. Health monitoring is general, surveillance is specific. Well, I know that I used measles as an example for health monitoring. But just put it in our head, I mean your head, in everybody's head, that when they say health monitoring, they are referring to general health monitoring. I used measles as an example to explain this diagram here so that we can understand it, just to make it more practical for us. Surveillance is more specific. So surveillance is related to particular diseases. If they say surveillance, you will ask the person that which particular disease or which particular health-related event are we talking about? Is it TB? Is it cholera? Is it yellow fever? So it's disease specific. Okay? Now there are two types of surveillance that was explained in our material. And I'll try to stick to those two, but there are more. So I've listed them here: active surveillance and passive surveillance. For active surveillance, okay, I said there are more. So you can check those ones up. There's like syndromic surveillance, there's sentinel surveillance, and a couple other. But the ones that was mentioned in our text, which I'm going to stick with, is active and passive surveillance. Two of them, they have their use cases. They have the places where they are important. They have their use cases. So let me explain passive surveillance. Passive surveillance is the kind of surveillance where, let's say let's use measles as an example. So for passive surveillance, what's happening there is that we're basically going to be in our offices as public health practitioners, and we'll be receiving the data maybe from laboratories, maybe from hospitals, to say we are seeing this number of cases, this number of measles cases. That's passive. You are going to be where you are and the report will be coming to you. That's basically passive. It's passive surveillance, okay? Well, for active surveillance, what is happening in active surveillance is that now we go carry our legs to go into the community to begin find the people that have these diseases or the people who are affected by these health-related events. That's active surveillance, okay? So if it's cholera, for instance, you're not going to be waiting for the hospitals to say, we are seeing this number of cases. No, we are going to go into the community and try to diagnose and try to carry out tests to find out who has it and who doesn't have this thing. That's active. Both of them, they have cases where they are useful. We can't always do active surveillance. That's one of the limitations. We can't always do active surveillance because it takes time, it takes money, it takes resources. If you say you want to carry us now and say, okay, let's go to the communities and start looking for this and looking for that, it's resource intensive. But there's a time where there are some cases that we cannot just sit and be waiting for the results, for the report, for the data to come. We have to go out there and look for it ourselves, because those things, like maybe they are very morbid, or the rate of mortality is a lot, or or it's something that we can't just sit down and be waiting for the data to come in. That's where we can do active. For certain kinds of outbreak, we need to do active surveillance. All right. Then I've already explained passive surveillance. So both of them, they have like their use cases, their cases where they are important. There's also, I said I won't go into details about those ones, but there's like sentinel surveillance. What's happening in sentinel surveillance is like they are designated centers. Sometimes it's things like maybe Lassa fever. You would have designated centers where they are the ones carrying out the test and they are the ones giving the report up that this is what's happening. So that's sentinel. Is like they are special centers basically that report those specific cases. So that's for, am I recording? Okay. So that's for sentinel surveillance. There's syndromic surveillance. Syndromic surveillance is something that we use in the early phases of an outbreak, where we cannot even be waiting before the lab results will start to come out or anything. Syndromic is like, if you see this symptom, please report the case. Sometimes, let's say if it's for fever, you can say, if it's for measles, you can say, if you see a child that has fever, the child has conjunctivitis, the child has rashes, please report this case. That is syndromic surveillance. Now, we are not saying we want to confirm and be sure that this person, that this thing is measles, so we want to do lab tests and clinical. No, syndromic is usually done at the early phase of an outbreak. That's syndromic surveillance. While sentinel is the surveillance where there are special centers that report these cases. They are sentinels, they give information. They are mounted there to get data for these particular cases. And then we've explained active and passive surveillance. So that will do for it. Okay, now we now have the third component of assessment, which is needs assessment. And for needs assessment, what is happening in needs assessment? If you've gone through your COPC, that's MPH 8105, you would understand what needs assessment is all about. Needs assessment is how do I explain it now? You know, for surveillance, I was saying, you know, I was mentioning specific diseases. I was saying cholera, I was saying measles, TB, etc., etc. But for needs assessment, what is happening here is that we're not really focusing on particular diseases. What we're doing is going into communities and trying to even the needs that we don't know they have, unmet needs that we don't know yet, emerging needs that we've not yet even identified before, that, oh, this is a problem for this community or anything. We are going there to do needs assessment, and in needs assessment, we just take we take data, both quantitative, qualitative data, and we do what they call like triangulation. And what we are trying to see is, okay, so what are the problems in this community? Unlike surveillance, where there's a particular thing that is something in our mind already, like there's something in our head already that we are going to look for or looking out for the report. But needs assessment is, let's go to this, let's even go to this community, let's do survey, let's ask them questions, you know, let's collect data in different forms. From this data, we'll be able to see what are the problems in this community. This is similar to what we are doing in COPC with Makoko East community. We were giving data, we're giving prevalence of different diseases and health-related conditions. And then we are also giving, you know, insights from the community, qualitative data, where they are saying, our water bad, oh, our water is bad, our water, they kill us, our water not good for us. Or some of our women, then they born them if they want, they born children, some of them are dying. So this one now is something that it will be like something that comes out, an output of, you know, all the data we're able to get from the community. You see, when we're going to Makoko, it was not like we had a particular disease in mind to say, this community, no, the thing we're going to manage people for, the thing we're going to handle in this community is let me say tuberculosis. No, that's not the way it was. We are going there, we look at the data. So you get to the community, you check the quantitative data, maybe from healthcare facilities. You can ask the doctors, you can ask the nurses, the community health workers there, you can ask them, what cases are we seeing more of it in this community? What are the cases we often see in the healthcare facilities? And then they can say, we see a lot of cholera cases, like Makoko East. We see a lot of cholera cases. We see a lot of people with malaria. We see a lot of these cases. That's quantitative data. They can tell you that we on the average in a month, we can see our cases, we can see like 50 of this, we can see this of this. Quantitative data, we gather it. We also now do what? Qualitative data, where we go into the community. Sometimes it will require, you know, there's the one they call the transect walk, where somebody takes you around the community for you to see how they even live in this community, for you to see the conditions of the environment in that community. It may also require like participatory approaches, where you try to engage the community and tell them, okay, give us key persons. Let's look at this community together and see the health status of this community. It can involve focus group discussions where we say, okay, let's have discussions on this. Tell me what are the challenges you are having? Or key informant interviews. Mapping, visual mapping. So all of these things, we gather all of these data, and then we now come to sit down. It's just exactly what is happening in our COPC. You now sit down and now look at it. You say, okay, let's weigh it based on severity, based on community concern, based on this. Which ones are the more pressing needs in this community? That's needs assessment. So I guess we know the difference now between them. Okay? So after we have done all these things, after we have looked at every, and we've been able to identify the wahala. So we've done our assessment and we've been able to identify the problem. What's now the next move? We now move to this oga here, policy development. That's now the next stop. Policy development is acting like a bridge between understanding problems and implementing solutions. Policy development is at the middle. So what's happening in policy development? In policy development, it means that we've done our needs assessment, we've done surveillance, we've done our health monitoring, and we have been able to come to think of it. Sorry, I'm just thinking aloud. Sure. This diagram here is actually more in keeping with. Anyways, let's follow what's on the textbook. Okay, so policy development, right? We've seen all the wahala, we've seen all the problems, we've done assessments, and now we now want to do what? We now come up with ideas. So we've seen that more children are coming down with measles. We're having more cases of measles. It's increasing. From our surveillance, it's increasing. It's a problem. So an example of policy development would now be, should we do a mass vaccination instead of the routine vaccination where it's age dependent, at this age you come for your vaccine and all that. Should we go beyond routine vaccination? Should we do mass vaccination, like just go into the community and start vaccinating all the kids that are eligible to be vaccinated? Should we do that? Should we do, instead of one vaccine dose, should we make it 2? Should we make it 3 vaccine doses? That's ideas now coming in. And all of these ideas, they are based on the data we got from our assessment. So we're going to formulate policies. And policies have to be evidence-based. You can't formulate policy based on vibes. See, I feel saying that this thing will work. No, it has to be based on evidence. There has to be, you source for evidence, you synthesize that evidence. So sometimes you see like if you go to WHO website, you can read some of their papers. You see that they can even begin from what they call expert opinion, to ask experts that, what do you think? Should we do another vaccination for kids? Maybe pediatricians, nurses, other healthcare workers. What do you think? You see expert opinions. Let's get an opinion from experts in this field. And then you say, okay, let's move into the research. Let's see, what does the science say? What does science say about this? Would it be necessary for us to do this? So let's see what research is telling us. So there's going to be what synthesis, all those papers that we put out online. You see, they bring them together and they start weighing them. Okay, let's bring all these results together and make sense of them and see how we can apply them to our context. So that's when we say policy has to be evidence-based. And it has to be contextual. We're also going to engage all the necessary stakeholders. Sorry that I didn't make it draw out the whatever under policy development before we started. If I try to do it now, it's just going to take a lot of time from me because I'm still learning how to use this thing. Okay? So policies have to be evidence-based and they have to be participatory. The people who are going to be affected by that policy, all the necessary stakeholders. If you have read like MPH 8111, they talk about policy analysis there, engagement of stakeholders, and they define who stakeholders are. Stakeholders are people that have what? Interest and what? Who knows the second I? Interest and what? Influence. Okay? People who have interest and people who have influence over a particular thing. Those are the people we refer to as the stakeholders. So policy development, it has to be participatory. By participatory, all the people who are stakeholders, all the people who are going to be impacted by that policy, whether directly or indirectly. In fact, stakeholders, you have like primary stakeholders, secondary stakeholders, and tertiary stakeholders. Primary stakeholders, let's use this measles as an example again. The primary, thank you, favor, yes, interest and influence. The primary stakeholders are who? Are going to be the children. The children that we want to vaccinate, they are the primary stakeholders. Because now their body, they are the ones that will receive the vaccine. So the children and their caregivers, their mothers, their fathers, their caregivers, those are who we refer to as the primary stakeholders. We are using measles as an example. So we want to make this our policy that, okay, should we make two, should we do two, should we do three, should we do four? If we want to develop this policy, we have to find a way to involve the people who are what? The primary stakeholders. And since children may not be able to, it's going to be their caregivers. Then we have secondary stakeholders. Secondary stakeholders are going to be people like the healthcare workers, the people who will give the vaccine, the people who are going to be in charge of implementing these things. They are going to be like the secondary stakeholders in this case. And then we have tertiary stakeholders, the people who will bring the money. Not be them will give the vaccine, but they are bringing the funds. They are going to be the ones to, ensure that the policy takes place, like the government. Those are who? The tertiary stakeholders. So all of these stakeholders that we are mentioning now, they have to be engaged. It has to be participatory. Everybody needs to come on board. Okay? So we've already mentioned that our policies must be evidence-based. Then we also mentioned that they should be what? They should be participatory. They should be participatory. Okay? Now, still under stakeholder engagements, because they went a bit to talk more about it. So we do something called stakeholder mapping. Stakeholder mapping. Before you start to even engage the stakeholders, you have to do a stakeholder mapping. In that stakeholder mapping, that's where, when we talk about the primary, tertiary, what is it called? Primary, tertiary, and primary, secondary, and tertiary, where you map out who are the primary stakeholders, who are the secondary stakeholders, who are the tertiary stakeholders. You do all of those things that we've learned that I mentioned in MPH 8111, where you do the power grid, see what are their interests, what's the level of interest they have, what's their level of interest, what's their level of influence in this particular case that we want to make policy for. So you do your stakeholder mapping, you do your stakeholder analysis, and then you engage the stakeholders. Another thing we need to note is the timing of engagement. It's not like once we say, we need to engage stakeholders, okay, everybody, primary, secondary, everybody, all the Bogbaya, come, it's time, let's start. No, it's at different times that you're bringing in different stakeholders. So there are stakeholders that you bring in at the early phase. For instance, let's say this measles. The starting point would be from the start point would be mostly like epidemiologists. They are the ones that are going to even help us with evidence that we want to use to make our policy. So we need to bring them in at the early phase. You get? And then when it's, let me say, we now want to talk about how this policy will be implemented, we have to now bring in the funders, people that will bring money. So it's not like you pack all the stakeholders and everybody's going to start at the same time. No. To make it more effective, there are different times where you bring in the different stakeholders. Okay? So that's for stakeholder engagement. It's very necessary for policy development. Now, the other thing under policy development is we need to know about policy analysis framework. So what is happening in policy analysis framework? I really wish like I could have a board, like a whiteboard and marker. I prefer to write using this whiteboard on Zoom. I'm not yet used to it, but I should stop being old school and just catch up. Maybe next time I'll be better with it. So policy analysis framework, what's happening here is what? We need to, before we carry our policies and go and implement them in the community, we need to try to analyze our policy to see if it get head or not. Like we need to analyze our policies to see the best way to even go about it. And there are different frameworks for analysis of policy. So there are 3 that was mentioned in our book. They mentioned cost effectiveness policy. What is happening in cost effectiveness policy? So let's still go back to our measles example again. By the time we will say, okay, we check all the options we have, we say, okay, let's come down to, should we do routine vaccination or should we do mass vaccination? I'm just giving examples, right? The policy can be way more than this. It can be different from this. So these are just examples. And then the cost effectiveness is trying to see how, like, which one will give us good return on our money, which one good for us to put our money on top, to put our resources on top, which one good. So if it's on measles, we'll now say routine vaccination. Let us say we'll be able to vaccinate 3,000 children. We'll be able to vaccinate 3,000 children and, oh no, let's not use 3,000. We'll be able to vaccinate, let's say 30% of our children. If we're doing the routine vaccination, we'll be able to vaccinate 30% of our children. And what we are going to spend for this is going to be, let's say, $1 million. You now say, okay, if we now decide to do the mass vaccination, how is it going to be? You now say, we'll be able to do mass vaccination and we'll be able to vaccinate 90% of our children. So how much are we going to spend? You say, okay, we're going to spend this amount of money. So cost effectiveness analysis, what is basically happening in using that framework is trying to see which one is more effective cost-wise. Which one they better for us to put our resources on. We're trying to see which one is more effective. Which one will give us better, in quotes, return on investment. Although it's not investment, I'm just using it very loosely. But I guess we understand what I'm saying. Now, it has its limitation. Because the limitation is, if you're doing it, if we spend that amount of money, sometimes you may think, oh, it's just number of children vaccinated that we are looking at. That's what we are looking at in cost effectiveness, for instance. But there may be other outcomes that are not necessarily even health outcomes that thing we are going to do, it can have. There may be other outcomes that you may not even be able to assess. So that money that you want to spend, that you're thinking, maybe it's too much for this one. Maybe we should do this other one. But you can't even see that there are a lot of other benefits that may come with it that are not health benefits. So that's the challenge with cost effectiveness. I'm already coming to the end of this thing so that we can all like go to chill. Then we have the other framework for policy analysis, which is what? Health impact assessment. Health impact assessment. And what this does is basically saying that we need to be aware of the fact that it is not just health. Like all the policies is not, I don't know how, let me put it this way, that even in transportation and in every other sectors, we have to embed health into it. So it's not strictly, okay, if we're talking is only health, only in the health sector, no. We need to also look at all the other sectors and see how we can slot in health into it. Because there are many other sectors that can affect health that are not necessarily health that there's on in let me explain it this way now. Let's take for instance transportation. If people don't have good transportation to maybe go to healthcare facilities, or they don't even have means of transportation to take their kids to immunization center, you see that whatever we're going to do is not going to have head. So although we call it transportation sector, but we see that there's a health impact of it. So that's that framework. Having the awareness that other sectors have impact on health. And then there's the third one, which is multi-criteria decision analysis. This one tries to be more expansive, to say we know that there are a lot of things we need to consider when we want to come up with policies. It's not just cost effectiveness alone. It's not health impact alone, that there are so many things we need to consider. All right. So let's wrap it up with assurance. That's the third function of public health. We're almost done, my people. We're almost done. So assurance, that's the third function. Remember we said assessment is, I need to wipe all of this. Assessment is the place where, we are saying, this diagram here, this thing here is not related to assurance. So I just cannot start cleaning everything now. Okay, remember we said there's assessment, you found out that there's problem, you move on to policy development where you engage stakeholders, you bring in the community, try to make it participatory, and you do your analysis, and then you come up with policies. And if you now come up with policies, they say, that there's this thing they say that talk is cheap. So we've come up with policies, and so now, how do we make those policies to have impacts? How do we operationalize our policies? How do we implement our policies? It's now under assurance that we're talking about that. Okay? So that's where the assurance part comes into play. So assurance is talking about how do we deliver quality services? How do we ensure that our people have access to these services? Okay? Now, under assurance, there are three things there. It encompasses something called service delivery models. It has quality assurance methods. It has resource allocation strategies. So these are the three things under assurance. Service delivery model. Remember, in assurance, now we're talking about how we go actually do the work. This assurance is the operational heartbeat of public health. How we go take carry out our operations. We don't make policies. How we go take ensure say we dey implement our policies so that our people health go dey alright. That's assurance. And I said that there are 3 things under assurance. Under assurance, we are going to look at what service delivery models. Say how do we deliver services? There are different models for service delivery. Okay, and then we look at what something called quality assurance method. How to ensure that the service we are delivering that it's of good quality. There is not rubbish quality services that we are delivering. And then resource allocation. How do we allocate our resources properly as we're doing as we're rendering services? Okay, so under service delivery models, there are different ways to deliver services. And when you go back to study it, you study it in better details, because I will just end here. There's the primary healthcare model. In primary healthcare model, we are combining clinical services with making it community-based, going into the community and seeing how they live in the community and how we can integrate that knowledge into the services that we are rendering. Primary healthcare, they are like the first point of contact, or they are meant to be the first point of contact between the healthcare sector and the community, members of the community. Okay, so that is for primary healthcare model of service delivery. There's also like community-based service delivery. There's digital service delivery. So when you go back to study, you can take a look, take better look at these things. So that's for the service delivery models. Then we have quality assurance methods. Under quality assurance methods, what we are doing there, like I said, is to make sure that we are giving what? Good quality services. So we are looking at the technical quality of our services. By technical quality, what are we talking about? Our diagnosis, for instance, you want to make diagnosis, the test kits we are using, hope they are working properly, hope they are diagnosing properly. Hope the healthcare workers are following the stipulated guidelines. Hope we're not just going there and doing anything we like. No, that we are following the guidelines that have been laid down for us. That's the technical aspect of it. Then there's the part where we are looking at patient experience. What's the patient's perception of the care that they are receiving? What's their experience of the care they are getting? Do they feel it's coordinated? Is it coordinated enough for them? Are they being communicated to effectively? So all of these things are the things we are looking at under what? Under quality assurance. Then there's resource allocation. So we've said what? We've said there's service delivery. There's what again? After service delivery, we mentioned quality assurance. After quality assurance, we said what now? Resource allocation. So how are we setting our priorities right to make sure that, you know, it's equitable, that people who actually need these services, that they are getting the services they need? So that's it for assurance. So these are the core services, or the core functions of public health. These are the core functions. So the other things you would see in this part A, it will talk about performance management in public health, accountability mechanisms. All those things are things that when you just go to read them, because you already have this background, you're going to just sweep through it. Then the part B of this now talks about essential public health services, and I have explained the link between the core functions and the essential public health services, such that if you missed it, I'm going to upload this video on YouTube. You can just take a look at it and or watch the earlier part, and you will get the link between the core functions and the essential services. So when you go back to study, it's just going to be like easy peasy. All right, this is the end. We've come to the end of it. Guys, thank you so much for joining. Thank you so much. It was really awkward just talking to myself initially. So thank you for joining. Um, Anytime I just have the chance, I'm going to just put up a link and tell us to join anybody who is free, so that I will just rattle and we'll listen. All right, guys. Can go back to your work or anything that we were doing. I hope that it was helpful to all of us. Take care, my people. Thank you, Aisha. Thank you so much. Thank you, guys.